Stop. Before you take your vitamins this morning, watch this first. Every single day, millions of people over the age of 60 take vitamin B12. They take it because their doctor told them to. They take it because they read it was good for energy. They take it because someone at the pharmacy suggested it. And most of the time, it is good for them. But here is what almost nobody is telling you. If you are also taking certain common medications that are prescribed to tens of millions of older adults in America alone, then taking B12 at the wrong time, in the wrong form, or in the wrong dose, could be quietly working against your health. Not in a dramatic emergency room kind of way, but in a slow, subtle way that affects your heart, your nerves, your kidneys, and your quality of life. Today, I am going to walk you through exactly what those two medications are, why the interaction happens, what the science actually says, and most importantly, what you should do instead. I have spent over 2 decades working in cardiology and internal medicine. I have seen firsthand what happens when well-meaning patients unknowingly create problems by combining supplements with their prescriptions. This video is not meant to scare you. It is meant to inform you, because information is the most powerful medicine there is. Stay with me through this entire video. Every section builds on the last. And at the end, I will give you a simple, practical checklist you can take to your next doctor's appointment. Let's begin. But real quick before we dive in, if you're new here, welcome. This channel is all about giving you honest, practical health information that actually helps you make better decisions for yourself and your family. We are on a mission to reach 1,000 subscribers, and every single person who joins this community genuinely matters to us. So if you find today's video helpful, please hit that subscribe button and ring the notification bell. It costs you nothing, and it means the absolute world to us. Okay, now let's really get into it. Part 2. Understanding vitamin B12. The basics. Before we talk about the interactions, I want to make sure we are all on the same page about what vitamin B12 actually is and why it matters so much after the age of 60. Vitamin B12, also called cobalamin, is a water-soluble vitamin. That means your body does not store large reserves of it the way it stores fat-soluble vitamins. You need a steady, regular supply. B12 plays a critical role in 3 major systems in your body. Number 1, your red blood cells. B12 is essential for the production of healthy red blood cells. Without enough of it, your body produces red blood cells that are too large and misshapen. They cannot carry oxygen efficiently. The result is a condition called megaloblastic anemia, and its symptoms are fatigue, weakness, shortness of breath, and brain fog. Number 2, your nervous system. B12 is required to maintain the myelin sheath. Think of that as the insulation coating around your nerve fibers. Without enough B12, that insulation breaks down. Nerves misfire. You get tingling in your hands and feet. You get balance problems. In severe cases, you get cognitive decline. Number 3, your cardiovascular system. This is where it gets especially important for people over 60. B12, along with folate and B6, helps your body process a molecule called homocysteine. Homocysteine is a naturally occurring amino acid, but when levels build up in the blood, it becomes toxic to blood vessels. It damages the inner lining of arteries. It promotes inflammation. It accelerates atherosclerosis, the hardening and narrowing of arteries. Elevated homocysteine is now considered an independent risk factor for heart attack, stroke, and peripheral artery disease. B12 keeps homocysteine under control. That is one of the reasons cardiologists pay such close attention to it. Now, here is the aging factor. As you get older, your body's ability to absorb B12 changes dramatically. B12 from food, from meat, fish, eggs, dairy, is bound to proteins. To release it, your stomach must produce adequate amounts of hydrochloric acid. Your stomach also produces a special protein called intrinsic factor, which is essential for B12 to be absorbed in the small intestine. Here is the problem. As we age, stomach acid production naturally decreases. This is called hypochlorhydria. By some estimates, between 10% and 30% of adults over the age of 60 have significantly reduced stomach acid. Less stomach acid means less ability to release B12 from food. Even if you eat a perfectly balanced diet with plenty of B12-rich foods, your aging gut may not be absorbing it properly. This is why doctors routinely recommend B12 supplementation for older adults, and why blood levels of B12 should be monitored regularly after age 60. But, and this is crucial, the way you supplement, the form you take, the timing, and what else you are taking alongside it, all of that matters enormously. Which brings us to the heart of today's video. Part 3. The first medication, Metformin. The first medication I need to talk about is Metformin. If you or someone you love has been diagnosed with type 2 diabetes or prediabetes, there's a very good chance Metformin is already in your medication cabinet. It is one of the most prescribed drugs in the world. In the United States alone, it is dispensed hundreds of millions of times each year. Metformin works by reducing the amount of glucose your liver releases into the bloodstream and improving your cells' sensitivity to insulin. It is generally well tolerated, inexpensive, and has been used safely for decades. So, what is the problem? Here is what most patients are never told. Metformin interferes with the absorption of vitamin B12, and it does so in a significant and measurable way. The mechanism was identified years ago, and the research is consistent. Metformin appears to reduce the calcium-dependent binding of the intrinsic factor B12 complex to receptors in the terminal ileum, the last section of your small intestine where B12 is absorbed. In plain terms, Metformin makes it harder for your gut to grab onto B12 and pull it into your bloodstream. Studies have shown that long-term Metformin use is associated with a 10% to 30% reduction in vitamin B12 levels. Some research has shown even larger reductions with higher doses or longer duration of use. A landmark study published in the journal Diabetes Care followed patients on long-term metformin therapy and found that a substantial portion developed clinically low B12 levels, many without any obvious symptoms at first. And here is where it becomes a genuine health concern for people over 60. You already have reduced stomach acid. Your intrinsic factor production may already be declining. Your baseline B12 absorption is already compromised by age. Now add metformin on top of that. You are now hitting B12 absorption from two directions simultaneously. And because B12 deficiency develops slowly, sometimes over months or years, you may not notice anything is wrong until real damage has been done. What does B12 deficiency caused by metformin actually look like in real patients? The symptoms are often subtle at first. And here is the dangerous part. Some of them can look exactly like complications of diabetes itself, which means they get misattributed and the underlying deficiency goes untreated. Watch for peripheral neuropathy, tingling, numbness, or burning sensations in the hands, feet, or legs. This is one of the most common and overlooked signs. Many diabetic patients assume this is diabetic neuropathy when it is actually B12 deficiency neuropathy, or a combination of both. Fatigue and weakness, not the ordinary tiredness of a busy day, but a deep bone-level exhaustion that does not go away with rest. Cognitive changes, memory lapses, difficulty concentrating, mental fogginess. In older adults, this is sometimes mistaken for early-stage dementia. Balance problems, difficulty walking steadily, increased fall risk. Mood disturbances, depression, irritability, and anxiety can all be linked to B12 deficiency affecting brain chemistry. Elevated homocysteine. Even before B12 levels drop into a clinically deficient range, homocysteine can begin to rise, quietly increasing cardiovascular risk. Now, this does not mean you should stop taking metformin. Please do not do that without talking to your doctor. Metformin is an important life-preserving medication for millions of diabetic patients. What it means is this: if you take metformin, especially if you have been taking it for more than a year, your B12 levels need to be monitored regularly, and you may need to supplement strategically. The American Diabetes Association has acknowledged this interaction and recommends periodic B12 monitoring for patients on long-term metformin therapy. Yet surveys consistently show that many patients on metformin have never had their B12 levels tested. If that is you, you now have the information to change that at your next appointment. Later in this video, I will walk you through exactly what to ask your doctor, what tests to request, and what forms of B12 supplementation work best when metformin is in the picture. But first, let's talk about the second medication. Part 4. The second medication, Proton Pump Inhibitors, PPIs. The second category of medications I want to discuss may surprise you even more than metformin, because these drugs are so common, so widely used, and so casually prescribed that many people do not even think of them as serious medications. I am talking about proton pump inhibitors, or PPIs. These are medications like Omeprazole, brand name Prilosec, Omeprazole, brand name Nexium, Pantoprazole, brand name Proton, Lansoprazole, brand name Prevacid, Omeprazole, brand name Acifex. PPIs are prescribed for heartburn, acid reflux, GERD, gastroesophageal reflux disease, stomach ulcers, and to protect the stomach lining in patients who take NSAIDs like aspirin or ibuprofen regularly. Here is the staggering reality. PPIs are among the most prescribed drug classes in the world. In the United States, tens of millions of prescriptions are written for them every year, and beyond prescription versions, lower-dose PPIs are available over the counter, meaning many people are taking them without any medical supervision at all. For short-term use, a few weeks to treat an acute problem, PPIs are generally considered safe and effective. But here is the issue. A very large percentage of people who start PPIs stay on them for months, years, sometimes decades. And long-term use of PPIs has a well-documented effect on vitamin B12 absorption. Remember what I explained earlier? B12 from food is bound to proteins. Your stomach acid, hydrochloric acid, is what releases B12 from those proteins. Without adequate acid, B12 stays locked up and cannot be absorbed. PP is work by dramatically reducing your stomach's acid production. That is the whole point of them. Suppress acid, relieve symptoms. But in doing so, they also suppress one of the key steps in B12 absorption. Research has shown that people who take PPIs for 2 or more years have a significantly higher risk of vitamin B12 deficiency compared to those who do not take PPIs. A major study published in JAMA, one of the most respected medical journals in the world, examined over 25,000 patients and found that long-term PPI use was associated with a notably increased risk of B12 deficiency. Now, here is the compounding problem for people over 60. You already have age-related reduction in stomach acid. PPIs reduce it further, intentionally. So once again, you are stacking one absorption problem on top of another. And unlike metformin, where the interaction is less widely known, the PPI-B12 connection is actually documented clearly enough that the FDA and various health agencies have issued communications about it, but awareness among patients remains surprisingly low. The dose and duration factor. An important nuance. The B12 absorption problem with PPIs is strongly related to dose and duration. Short-term, lower-dose PPI use is much less likely to cause a clinically significant problem. The concern rises substantially with use lasting more than 12 months, higher prescribed doses, already low baseline B12, common in older adults, concurrent use of other B12 depleting medications like metformin. That last point is critical. What if you are a diabetic patient over 60 who takes both metformin and a PPI? That combination, which is extremely common, creates a triple threat to your B12 status: age-related decline in intrinsic factor and stomach acid, metformin blocking intestinal absorption, and PP is further reducing the stomach acid needed to release dietary B12. Heart health considerations with long-term PP is. As a cardiologist, I also want to mention something that has emerged in more recent research regarding PPIs and cardiovascular health. Some studies have raised questions about potential associations between long-term, high-dose PPI use and certain cardiovascular risks, partly through effects on the gut microbiome, nitric oxide metabolism, and yes, indirectly through their contribution to B12 deficiency and rising homocysteine levels. I want to be careful here. The science on this is still evolving and not fully conclusive. But it is another reason why managing B12 levels carefully when you are on long-term PP is not just a nutritional concern. It may have cardiovascular implications. A word on over-the-counter. P is one more thing I want to address specifically. Over-the-counter. P is like Prilosec, OTC, and Nexium. 24HR are intended for short-term use, typically 14 days. The labels say this clearly. But many people treat them like long-term maintenance medications, buying them month after month without ever discussing it with a doctor. If you are doing this, please stop and have a conversation with your physician. There may be alternatives. There may be underlying causes of your acid reflux that can be addressed. And at minimum, if long-term acid suppression is necessary, your B12 status needs to be monitored. Part 5. The Science of the Interaction. Deeper dive. I want to take a few minutes to go a little deeper into the science here, because I think understanding the mechanism helps you appreciate why this is a real concern and not just a theoretical one. When you eat food containing B12, a piece of salmon, a chicken breast, an egg, the B12 in that food is tightly bound to proteins. Your stomach acid begins the process of separating B12 from those proteins. Then, chief cells in your stomach release pepsin, which further cleaves the protein bonds. Once freed, B12 binds to a protein called haptocorin, sometimes called R protein, for protection during its journey through the stomach. Then, in the small intestine, pancreatic enzymes break down haptocorin, and B12 binds to intrinsic factor, a glycoprotein produced by specialized cells in the stomach lining called parietal cells. The intrinsic factor B12 complex travels to the terminal ileum, where it binds to specific receptors called cubilin receptors, and B12 is absorbed into the bloodstream. Now, here is where both medications interfere. PP is suppress parietal cell function, dramatically reducing acid production. Without adequate acid, the initial release of B12 from dietary protein is impaired. The whole chain reaction stalls at the very first step. Metformin appears to interfere at a later stage, specifically at the calcium-dependent binding of the intrinsic factor B12 complex to cubilin receptors in the terminal ileum. The calcium-dependent nature of this interaction is why some research suggests that calcium supplementation may partially mitigate metformin's effect on B12 absorption, though this is not yet a universally accepted clinical recommendation and should only be done under medical supervision. The important takeaway here is that these are two distinct mechanisms targeting different steps of the same absorption process. Together, they are far more impactful than either one alone. And here is something many people do not realize. Your blood B12 levels can look normal even when your cells are functionally deficient. Standard blood. B12 tests measure total serum, B12, but a portion of that B12 is bound to a carrier protein called haptocorin and may not be bioavailable to cells. Functional markers like methylmalonic acid, MMA, and holotranscobalamin, active B12, give a more accurate picture of true B12 status. I'll come back to this in the action steps section. Part 6. Who is most at risk? Let me paint a clear picture of who needs to pay the most attention to everything we have discussed today. You are at elevated risk of clinically significant B12 problems related to these medications if you fit any of the following profiles. Profile 1, the diabetic senior. You are over 60. You have type 2 diabetes or prediabetes. You take metformin, especially at higher doses or for more than 1 year, and you have never had your B12 levels specifically tested. This is an extremely common and under-recognized situation. Profile 2, the reflux patient. You have been taking a PPI, prescription or over-the-counter, for more than a year. Maybe your original prescription was for an ulcer that healed, but you kept taking the medication because stopping caused rebound symptoms. Your B12 is quietly declining. Profile 3, the double medication patient. You take both metformin and a PPI, which, as I mentioned, is extremely common in older adults with diabetes and digestive issues. You have a compounded risk, and routine monitoring is essential. Profile 4, the vegetarian or vegan senior. Even without medications, vegetarians and vegans who are over 60 have limited dietary B12, since B12 comes almost exclusively from animal products. Adding metformin or PPI used to this profile creates a very high-risk situation. Profile 5, the patient with GI issues. Anyone who has had gastric bypass surgery, has atrophic gastritis, chronic stomach inflammation common in older adults, celiac disease, or Crohn's disease already has compromised B12 absorption. These conditions combined with either medication dramatically amplify the risk. If you recognized yourself in any of those profiles, please do not panic. Please do take action. The next section tells you exactly what to do. Part 7. The Action Plan. What to do now. This is the section I most want you to pay attention to, because knowledge without action changes nothing. Here are 7 clear, concrete steps you can take. Step 1. Get your B12 levels tested. Call your doctor's office and ask to have your vitamin B12 level tested at your next appointment. Ideally, ask for a full panel that includes serum B12, standard, methylmalonic acid, MMA. This rises when B12 is functionally deficient, even if serum B12 looks borderline normal. Homocysteine. This also rises with B12 and folate deficiency and is an independent cardiovascular risk marker. Holotranscobalamin, active B12. If available at your lab, this is the most sensitive early indicator. Write these down. Take the list to your appointment. Step 2. Talk to your doctor about your medication review. Ask your doctor specifically about B12 depletion risk from your current medications. This is a legitimate and important conversation. Ask, given that I take metformin/my PPI, should I be monitoring my B12 levels regularly? And if so, how often? Current evidence suggests annual B12 monitoring for patients on long-term metformin, and consideration of monitoring for patients on PP is for more than a year. Step 3. Discuss whether you still need your PP. Many patients are on PP is far longer than clinically necessary. Ask your doctor whether a gradual taper, combined with lifestyle modifications for acid reflux, might be appropriate. Lifestyle changes like raising the head of your bed, avoiding eating within 3 hours of bedtime, reducing trigger foods, and maintaining a healthy weight can dramatically reduce acid reflux symptoms in many people. Do not stop a PPI abruptly on your own. Rebound acid hypersecretion is a real phenomenon that can make symptoms temporarily worse. Work with your doctor on a thoughtful tapering plan if appropriate. Step 4. Choose the right form of B12 supplement. If your doctor recommends supplementation, the form matters significantly. Cyanocobalamin is the most common and cheapest form. It requires conversion in the body and is less ideal for people with genetic variants that affect B12 metabolism. Methylcobalamin is the active, bioavailable form. It requires no conversion and is generally preferred for neurological protection. Sublingual B12, dissolved under the tongue, bypasses the digestive system almost entirely, making it far superior for people whose gut absorption is compromised by either metformin or PPIs. For anyone taking these medications, sublingual delivery is often the recommended route. Intramuscular B12 injections completely bypass the gut. For patients with severe deficiency or very poor absorption, monthly injections may be the most effective option. Step 5. Time your supplements strategically. If you take a PPI, take it 30 to 60 minutes before meals as directed, but consider taking your B12 supplement at a completely separate time, not with other medications. Discuss with your pharmacist or doctor the optimal timing for your specific regimen. Do not assume that just because you are taking B12 alongside your other pills that it is being absorbed effectively. Step 6. Support B12 with its cofactors. B12 does not work alone in managing homocysteine. For optimal cardiovascular protection, it works in concert with vitamin B6, pyridoxine, folate, preferably as methylfolate, not folic acid for better bioavailability. Many physicians recommend a B-complex supplement rather than isolated B12, ensuring all 3 vitamins are adequately supplied. Ask your doctor about this. Step 7. Dietary optimization. While supplementation is often necessary, diet still matters. The best dietary sources of B12 include clams and shellfish, highest B12 content of any food; beef liver, wild-caught salmon and trout, sardines and tuna; eggs, particularly the yolk; dairy products, OG, food sources listed on screen with icons; BR, colorful spread of B12-rich foods, salmon, eggs, dairy. Focus on variety and frequency. Even if absorption is reduced, regular dietary intake provides ongoing support to your supplement regimen. Part 8. Closing summary. Let me bring everything together. Vitamin B12 is essential for your red blood cells, your nervous system, and your cardiovascular health. After age 60, your body's ability to absorb it naturally declines. 2 of the most commonly prescribed medications in older adults, Metformin and Proton Pump Inhibitors, can significantly further reduce your B12 absorption through different mechanisms. The result can be a slow, silent deficiency that causes nerve damage, cognitive decline, fatigue, balance problems, and elevated cardiovascular risk, often mistaken for normal aging or diabetes complications. The good news: this is entirely detectable and correctable with the right testing, the right supplement form, and the right conversation with your physician. You are not powerless here. You are informed, and now you can act. Share this video with someone you love who might be taking these medications. Leave a comment below telling me which profile resonated with you. And if you want me to do a deep dive video on any specific topic we covered today, homocysteine and heart disease, the best forms of B12, how to taper off Is safely, let me know. Thank you so much for spending this time with me today. Your health is worth every minute of it. Take care of yourself, and I will see you in the next video.